Good evening. Greetings from Southeast Asian Academy of Sleep Medicine monthly webinar. I thank all the CSM leaders, President Dr. Mahavir Modi, Secretary Dr. Shivani Swami, immediate past President Dr. Pradeepa Dogra, Patron of CSM Dr. Rajesh Swarnakar, and Founder President Himanshu Garsar, all the leaders behind the CSM. Every month, last Tuesday, we'll be conducting the regular CME webinar. So this is the sixth webinar. Today, there is a very interesting topic, restless leg syndrome and periodic leg movement disorder disease. That is, this comes under the sleep-related movement disorder. Today, we have a wonderful speaker, moderator, and panelist. So, welcome all the delegates, those who are logging in this prestigious CSM webinar. May I introduce and welcome today's speaker and moderator, the Professor Dr. Alkesh Kurana sir, Professor and HOD in Department of Pulmonary Medicine, All India Institute of Medical Science, Bhopal. So, sir has vast experience in sleep disorder and all kinds of sleep disorders. Sir is the working in various in the institutions, mainly the AIMS Bhopal, and the area of interest of Dr. Alkesh Kurana is tuberculosis, pulmonary rehabilitation, and critical care. So he has published more than 100 publications in the index journals. With that few intro, I request welcome Dr. Alkesh Kurana sir for the presentation. Followed by, we'll have a panel discussions with the eminent star panelist. So with that, I hand over the mic to Dr. Alkesh Kurana sir. Thank you, sir.
Thank you, Dr. Jaraman, sir. Thank you very much for being here. It's a privilege to be a part of this webinar series, and I'll be talking today about restless leg syndrome and periodic limb movement disorder, some very common and under-recognized entities. So before I start off with my presentation, I'd like to get you to the panelists of the session. We have, interestingly, 3 panelists for this session. One of them is a pulmonologist and 2 of them are neurologists. So you can ask as many questions as you can, provided time permits us to answer. So pulmonologist from the pulmonary side, Dr. Mahesh Babu is there from AIMS Vivinagar. Dr. Shinu Singla is a neurologist from AIMS Bhatinda. And Dr. H.M. Sahu is another neurologist from Varanasi. So we have 3 panelists here, 1 pulmonologist and 2 neurologists. And we'll be happy to take questions at the end of the session. Thank you all the panelists for being here. Thank you so much. So I think I'm permitted to start, Dr. Jayaraman, now, sir.
Yes, sir. Please go ahead, sir. Please, sir.
Yes. So there we are. We will be talking about restless leg syndrome and periodic limb movement disorder today. So see, when you this restless leg syndrome is not a new entity, one must remember. It was first described way back in 1945, so like so many 80 years around back. Also called as Willis-Ekbom disease. And the most interesting statement you will ever read about restless leg syndrome is it is the most common disorder you have never heard of. It's very, very interesting. When we actually started doing sleep medicine at our institute around 10 years back, and we read that and we started doing it, it was very interesting. These kind of patients come to your clinics and you just ignore them because you don't know that a disease like there exists in your vicinity here and there. So it's a very common syndrome, usually missed. Once you go through it, once you read through it, you will probably start diagnosing very frequently these cases. RLS is often associated with PLMS, which is the periodic leg movement syndrome, insomnia, excessive daytime sleepiness, etc., etc. Now, like any other disease, which has been described in the West in the beginning, we have far less data in epidemiology when we talk about. There are papers in India which have reported the prevalence of RLS from 2 to 15%, but these were not proper questionnaire-based studies. So the data is still, not very authentic. There are not much studies to comment on the prevalence of RLS as such. Worldwide, if you see, it has a very wide prevalence, around 9 to 15%. It is a huge, 10% of the whole world population, if you say, suffers from some extent of RLS, is something which you don't believe as such. And since RLS is related very, very commonly with anemia and to a lesser extent with diabetes, which are the predisposing factors for RLS, you expect, if a genuine study comes out there to find the prevalence of RLS on a huge scale, you expect a much higher prevalence in India. It's usually commonly seen in younger age group, but people have seen RLS in over 80 years of age group. Also more common in younger age group, in females especially, but can be seen in any age group. Now, what is the clinical presentation of RLS? It's a somatosensory network disorder. There is classical irresistible urge to move predominantly the legs. And how does the patient describe it? The patient will usually tell you a sensory symptom of prickling, crawling, aching, burning, tingling. They will have their own words, to describe this kind of a sensation in the legs, which urges them to move their legs, especially in the evening. More symptomatic in the evening, usually while sitting. So the urge is so much that the person has to get up from the bed or the chair and to have to stretch himself or herself or some walk before going to the bed again. That is irresistible urge there. And once the person stretches, does some mild exercise, it just gets better with activity. So there are patients, if you see either as a neurologist or a pulmonologist, as a physician, you will encounter patients, especially younger aged females in your OPD, whom we usually sometimes tend to label as functional and refer to psychiatry. So, these kind of patients, usually people will do that unless you know about the disease. Once you start picking these symptoms, then it is very easy to pick up the diagnosis, and these patients respond very well to treatment. So the diagnostic criteria were first laid down in 1995. You use this acronym URGE, which to remember the diagnostic criteria and the symptoms. U stands for urge to move the legs. Rest induced, it is more in rest, gets better with activity, and evening or night accentuation. So it's basically, urge itself is basically telling you what are the 4 cardinal diagnostic criteria or the symptoms of RLS. There are some additional features. You can see that there may or may not be concomitant PLMS. There may be sometimes a positive family history. And if untreated, it can lead to chronic progressive course with periodic exacerbations. So these symptoms or the diagnostic criteria in itself, which describe the symptoms, must be kept in mind. Not very difficult to remember though. So there are, if you go through the literature, you will find so many things in the literature. The neurologists will understand this part a bit better. What part of brain is involved, limbic system, strata nigra, and this and that. For us as pulmonologists, predominantly, you should remember that there is a role of dopaminergic pathway, and there is some kind of dopamine deficiency in certain areas of the brain, which has been proven by MRI as well. Hence, the symptoms are triggered by dopamine antagonists and alleviated by dopaminergic drugs. And it is not only about dopamine. You must understand that there is a strong correlation with iron also in some parts of the brain. I'm not going into the details of what parts of brain. That is, as per knowledge, that is not for us, but maybe neurologists can tell you better about that. So iron is a cofactor here in an enzyme called as tyrosine hydroxylase, which is essential for dopamine synthesis. And both iron deficiency leading on to dopamine deficiency in certain parts of brain causes or exacerbates or triggers the symptoms of RLS. This is something which you must remember. So both iron and dopamine play a role, and hence both these are the parts of the treatment as well. You can classify RLS in 2 types, something like early versus late onset, or you can also classify it as idiopathic versus secondary. The early onset, if you classify by this classification on the left hand side, you can see early versus late onset. Early onset is less than 45 years of age. It tends to cluster in families, sometimes, not always, with a female predisposition, females over males 2:1. Late onset, more than 45 years of age, equal male-female ratio, more rapid progression, and severer symptoms associated with sometimes myelopathy and neuropathy. You must have come across so many diseases in medical science, which early onset having a certain phenotype and late onset having a certain phenotype. Here also, just like that, early onset is a bit milder, late onset is a bit more severer with more rapid progression and more likely to be associated with some neurological diseases. Or you can also classify restless leg syndrome as idiopathic versus secondary. Idiopathic, no identifiable cause. Secondary, if there is certain kind of a pre-existing disease you have. It is much more common in renal disease, as it is linked to anemia, to CKD, associated diabetes mellitus, COPD, some neurological diseases like Parkinson's or hematological diseases. So till now what we have discussed is we have discussed about the clinical presentation of RLS, which itself tells you the diagnostic criteria: urge to move legs, rest induced, gets better with activity, and evening worsenings. Role of dopaminergic pathway: one must remember the role of iron and dopamine both. Therefore, iron and dopamine both play a part in the treatment of RLS as well. And then we talked about the classification: early versus late onset, or idiopathic versus secondary. So as with any other disease, what will happen if the person is suffering from RLS? Obviously, in severer cases, it can affect the quality of life. There are studies to label this having an increased risk of coronary artery disease as well. Association with metabolic dysfunction and autonomic dysfunction. It is associated with diabetes and impaired glucose tolerance, and that is why I mentioned in the first slide also, so that if a true prevalence study comes out of RLS, so because of high prevalence of diabetes and anemia in India, RLS could actually have a more than expected prevalence in India. And obviously, when you have such kind of a chronic disease, you will have psychological impairment and insomnia as the consequences. In younger population, it is more expected to have a insidious onset, and elderly population rapid onset. Just as we discussed here, you see, early onset and late onset. So late onset diseases, like many other medical diseases, will have a more rapid progression and severer symptoms. So also you can sometimes, based on the progression of the disease, you can label it as intermittent RLS, daily RS, or refractory RLS. This term, you see, refractory RLS is not a very standard uniform term, but a chronic persistent RLS is sometimes which is not very responsive to dopamine therapy or gabapentin nowadays. So you must remember that there is something called as chronic progressive RLS, or you can call it as refractory RLS, because this will have important implications in the treatment of the disease. So you must remember that this is a separate entity in itself. Any movement disorder will come into the differential diagnosis of RLS. Akathisias, Parkinson's, arthritis, hypnic jerks, fibromyalgia, nocturnal cramps. So they can all, depending on the age group, whether it is the child or the elderly age group, depending, because all these movement disorders will also have a varied prevalence in children as well as adults also. So depending on what age group patient you are seeing, you will have to keep a differential diagnosis for the same. Now we come to the management. It's an interesting part in management. I say it interesting because when you come across a single RLS patient, when you diagnose it a single RLS patient and you then start treating it, the response is so dramatic and so immediate that it's very rewarding for the patient as well as you. So as with any other sleep disorder, the general sleep hygiene is as important as the drugs, because remember, not all patients will need a medical therapy. We will have a tendency to start a drug in patients of RLS or any other syndrome to see quick results, but around half of the patients will actually need a pharmaceutical therapy. And in general, if you advise the patient and if the patient follows a general sleep hygiene, almost half of the patients can respond significantly with this management also. What are these features? Avoiding alcohol, caffeine, smoking. Good sleep hygiene means maintaining, there are so many points within the sleep hygiene, having a particular time to sleep, wake up sleep, not having coffee in the evening, and all those are part of good sleep hygiene. Moderate amount of evening exercise, hot baths or leg massage before bedtime, distraction by reading books, and sometimes pneumatic compression devices, which is of course rarely you will recommend anyone. But with other measures, the 4 or 5 parts which are lines which are written in the above part, if some of the patients, especially with milder symptoms, can actually manage with only sleep hygiene measures. Then there is a role of iron, because we discussed that iron deficiency and dopamine deficiency do play a part in the pathogenesis. Therefore, these two will have to come in the management part. So iron supplementation if ferritin levels less than 110. We will come to this part because the ferritin levels have been a subject of debate. What ferritin levels cutoff have to be taken to start oral supplementation iron or IV supplementation? We have one or two slides for that. We will come to that. Sometimes intravenous supplementation is required in chronic persistent RLS, or what you can call as severe RLS, or in patients with pregnancy-related RLS. And avoid dopaminergic blockers, avoid antipsychotics and antidepressants if any. Then we come to the other drugs. You see, as I said, sleep hygiene will take care of almost 50% of the patients, but the drugs will be required in the other half of the patients. And the most common drugs which have been conventionally used in the last 20, 25, 30 years is dopaminergics, namely pramipexole, pergolide, carbapenem, or levodopa as such. Opioid antagonists like tramadol, methadone, clonazepam, valproate. Mostly we have used with dopaminergic drugs. If I talk about my own personal experience, I have predominantly seen whatever patients I have and treated them with propranolol or pramipexole, only dopaminergic drugs. But so let's talk about these dopaminergic drugs. First, propranolol is a very, very commonly used drug used to treat RLS. Standard dose is 0.25 to 4 milligram per day. Personally speaking, when we have given patients these drugs, hardly ever we have required more than 0.5 milligram per day. Nausea, headache, fatigue, dizziness are there. Augmentation is one side effect which you must know, which happens with these drugs, and sometimes rebound phenomenon, or we will talk about augmentation, what it is. The same kind of thing is pramipexole, similar class of drugs, similar side effects, and the dosage slightly varies with ropinerol. Ropinerol is 0.25 to 0.5 milligram per day, and pramipexole is 0.125 to 0.75 milligram per day. But both of them have the same mechanism of action. Levodopa, usually predominantly by neurologists in Parkinson's and all, we have not used it, but just to label it 50 to 100 milligram per day, I have not used levodopa as such. Most of our patients have been treated with these two drugs only. But if you see these two slides, all these three dopaminergic drugs which have been conventionally used have this common side effect of augmentation. Now, what is augmentation? One must remember, it's kind of in simpler language, if I talk about, it's kind of a resistance developing to the drug. Okay, so the effect of the medicine which was supposed to last for 24 hours will now wane off, maybe in 16 hours, 20 hours. The medication wears off faster. So what will happen? Instead of you requiring the medicine after 24 hours, symptoms will start earlier in the day. Suppose you were giving the drug at 6 o'clock in the evening and every evening now, and it was initially covering the full 24 hours. Now the symptoms will start developing at 2 p.m., 3 p.m., 1 p.m. So you will, symptoms will start earlier, less than 24 hours have passed away. And the restless sensations may develop from legs which were there initially to the other body parts like arm and trunk. There will be increased overall severity of symptoms, and all these features will be precipitated by iron deficiency. So we have been repeatedly talking about the role of iron and dopamine. So wherever these two things are decreased, the symptoms will be worsened, and obviously proportional to the duration of treatment. So if these augmentation develops, we have to stop the culprit drug and shift to alternate non-dopaminergic medications. So this is what we have been doing since last few years, since I started practicing sleep medicine, and since most of the people in India have been doing. But however, in the recent guidelines, clinical practice guidelines in 2024, these so-called dopaminergic drugs, these three drugs which we have been talking, they are now, taken off the list. Now these are not the first line of drugs. So people, even if you have been using these drugs, these are now conditionally recommended against by the CPG guidelines in 2024 by the American Academy of Sleep Medicine. And now the focus has shifted to this group of drugs which are called as the alpha 2 delta ligand calcium channel blockers, which are called as gabapentin, anacarbil, pregabalin, and IV formulation of ferric carboxymaltose, which is an IV formulation of iron. So one must remember that these conventional drugs are now shifted to this group of drugs which are called as alpha 2 delta ligand calcium channel blockers, namely gabapentin, the two congeners gabapentin anacarbil, pregabalin, and iron, the most common preparation being intravenous ferric carboxymaltose. I will admit it that I myself have limited experience in giving these drugs because these guidelines have changed recently, and we as pulmonologists are not very comfortable in giving gabapentin, especially with gabapentin anacarbil, which is actually presently not available in India to the best of my knowledge. This will be, I think, discussed with the neurologist in the panel discussion. This must be discussed in the end. So when we talk about iron therapy, we have talked about dopamine therapy. Then we talked about iron therapy for RLS. So for all RLS patients, oral iron should be given if the serum ferritin is less than 75 microgram and transferrin saturation is less than 45%. So you must get the iron studies done in every RLS patient. And if there is something called as chronic persistent RLS, as I discussed initially just 5-10 minutes back, that you must remember there is something called as refractory RLS, there is something called as chronic persistent RLS. So in these patients, you must go with intravenous iron, even if the serum ferritin is more than 75 and saturation is less than, transferrin saturation is less than 45%. In this subgroup of patients, oral iron is not adequately absorbed. So basically remembering, most of your patients will settle down in oral iron with or without gabapentin or without dopaminergic drugs, which presently are not to be used. But rarely you will come across a patient in which intravenous iron will be used. See, we are talking about management, but you must always remember after this presentation, after today's webinar, is to go back and first start diagnosing RLS patients. And once you see a patient, suppose you are seeing 100-patient OPD in a private, in a government hospital, or even a 20-patient, 25-patient OPD in a private hospital, you will definitely come across one patient in 2-3 days. Definitely it will come. It is because we don't know it, we don't pick it up, and we don't treat it. And these patients keep on wandering around here and there in different departments, and sometimes refer to psychiatry also. So when we talk about iron therapy for RLS, there is one slide which I'm going to talk about is ferric carboxymaltose. This is the preferred parenteral drug. When you look at the IV formulations of iron, this is the preferred parenteral drug, ferric carboxymaltose, because high doses up to 1000 milligram can be given in single or two doses. If it effectively crosses into CNS to restore brain iron, and it has a long-lasting effect up to weeks with a single dose. And as mentioned, the mechanism in the literature is because it has a stable carbohydrate shell which releases the iron slowly, so it lowers the risk of free iron toxicity while helping the body absorb it into target tissues. So one must remember that we have to give IV formulation. Orofox or something like that is the trade name for this. Orofor I think is the trade name for this particular IV formulation of iron. You must remember the name ferric carboxymaltose. Then when we talk about this 2024 clinical practice guideline update, so there is also a conditional recommendation for extended release oxycodone, dipyridamole, and bilateral high frequency peroneal nerve stimulation. To mention it, I haven't used it. I hardly believe, as per knowledge, we have used it. Maybe the neurologist will tell you better that if they have any experience with this kind of a treatment or not. So, yes. So, this is now we come to the actual management slide. Till now, we have talked about the 3 dopaminergic drugs, which are now not recommended by the American Academy of Sleep Medicine. We have talked about some iron therapy, which is not very commonly required, especially IV iron. Oral iron will supplement and be a part of your treatment very commonly. Now we actually come how we have evolved from the previous treatment to the current treatment recommendations. So now these are the drugs which are currently recommended by the experts, by the ASM and other experts worldwide. So these drugs include our pregabalin, which is considered at first line by many nowadays because, as I mentioned in the CPG update, it targets calcium channels to calm the nerve activity. There is no problem of augmentation, and augmentation was one phenomena because of which these dopaminergic drugs have been, labeled as not to be used, conditional against recommendations. So avoiding pre-existing gait abnormalities, these drugs. Gabapentin is one drug which targets another calcium channel ligands like this pregabalin also. There is side effect of dizziness, drowsiness, and unsteadiness, and it is used for refractory RLS sometimes. So when we talk about this, one slide I have deliberately added to differentiate between gabapentin and gabapentin enacarbil. Now I am again honestly admitting with you, we have been treating majority of the patient with dopaminergic drugs. We have limited experience with gabapentin and these drugs, especially this drug which is on the writer side, gabapentin enacarbil. I inquired it from places across MP where I serve. The trade name is Horizon, but it is not available at least in Madhya Pradesh. I don't know about India. People, this is also a point of discussion. So gabapentin is less predictable, has got less predictable absorption. It is to be given 3 times a day, mainly for seizures and post-herpetic neuralgia. Now this drug, Horizon, which is the trade name, and gabapentin enacarbil, which is the drug, it has a better bioavailability. It is given only once or twice a day. This drug, it is a kind of a pro-drug for gabapentin. So gabapentin enacarbil is a pro-drug for gabapentin, and this one is specifically approved for RLS and post-herpetic neuralgia. So this is all about RLS. So I will just sum up. We will come to the PLMS. That part is still there in the presentation. So we'll just try to summarize RLS. What have we discussed so far? So we talked about RLS. The first thing which I am repeatedly saying for all the audience is to first learn to diagnose RLS. RLS is something which is missed very frequently in the OPDs. You must first diagnose the RLS. And when you diagnose RLS, this is just theoretical part, early onset, late onset, idiopathic, secondary, consequences, causes, differential diagnosis, and treatment part. I repeat, 50% of the patients will get better with sleep hygiene measures, and 50% of the patients will need pharmaceutical therapy. Predominantly, conventionally, it was the dopaminergic drugs, which is no longer recommended nowadays. Nowadays, the preferred drugs are this gabapentin, pregabalin, and especially gabapentin, anacarbil, which is the prodrug for gabapentin. But still, a lot of people usually might be using dopaminergic drugs for now as well, because we don't have the treatment of choice or the horizontal available in India as of now. So now we come to the second part of the presentation, which is the periodic limb movement syndrome, or what we commonly call as PLMS. It's another motor disorder which usually occurs typically during sleep. Most of the patients with RLS will have PLMS, but a lesser number, only 30% of PLMS will have RLS. Okay. Now, please understand, RLS is a clinical diagnosis. You can diagnose patients of RLS sitting in your OPD. You do not need a polysomnography to diagnose RLS. Whereas PLMS itself, the nomenclature says during sleep, so this will require a PSG for a diagnosis. RLS can be, diagnosed in OPD very easily in outpatient clinics, whereas PLMS will need a PSG for diagnosis. That differentiates in the diagnostic part between PLMS and RLS. There are certain diagnostic criteria when you actually look at the level 1 PSG and you have all that facilities and you have to make a diagnosis of PSG. Then these are certain diagnostic criteria which help you to see whether the patient falls into the diagnostic criteria of PLMS or not. Minimum duration of leg movement 0.5 to 10 seconds, amplitude 8 microvolts or more. For more than 4 leg movements separated by at least 5 seconds, but more than 90 seconds may or may not be associated with EEG arousals. These are the diagnostic criteria when you use to diagnose PLMS when you interpret a level 1 PSG. And just as if you have a AHI index for OSA, similarly you have a periodic limb movement index for this. Less than 25 mild, 25 to 50 moderate, and more than 50 severe. Must always, just one line here, that in children the PLMI cutoff is only 5 per hour is taken than abnormal. Just like you have a separate cutoff criteria for AHI to diagnose OSA in children, similarly you have a different cutoff criteria for diagnosing PLMS in children. There are certain, nowadays you talk about asthma, you talk about COPD, you talk about ILD and everything, and you all have, all these researches nowadays happening on classifying different diseases into different phenotypes. Similarly, you have separate phenotypes which have been, labeled for PLMS also. Something which is called as genuine PLMS, just like the diagnostic criteria we described here. Some PLMS with arousals, some PLMS is, dominant comorbidity cluster. This is very interesting because even before we started the webinar, there was a question in the chat box which was linked to this particular part. There can be incidental detection of PLMS in a patient of OSA, which is very common. So PLMS here is overshadowed by the OSA, which is the predominantly thing which is bringing the patient to the PSG lab. That is one phenotype. Whether or not to treat that PLMS, that is a matter of debate. Then there is an isolated non-arousing phenotype. Just, there are phenotypes in PLMS also. What is the clinical significance of that? That is a matter of research and debate. We will come to that. Then in children, I just mentioned that the cutoff is only 5 per hour. Periodicity of leg movements is uncommon. Sometimes there may be a variation with high altitude, but this is one thing that patients, children with attention deficit hyperkinetic disorder, ADHD, there you will find more and more prevalence of PLMS. ADHD and PLMS in children are very strongly interlinked with each other. It can be associated with growing pains in children. Sometimes in children, it is said that PLMS may precede RLS. So that, I don't know how much clinical significance has this is, because basically in our country, the accessibility to PSG is very limited. Then we are talking about diagnosing PLMS in children. So we are talking, what we are talking about. It's basically a theoretical concept, but practically how much it is relevant, even I don't know that. So there are patterns of sleep. This is the classic pattern. The A pattern, which I have mentioned in the slide here, this is the classic PLMS pattern. What to learn from this pattern is PLMS commonly starts in N1, predominates in N2, less frequent in N3, and disappears in REM sleep. So predominantly PLMS will occur more commonly in the first half of sleep. It will subside in N3 and REM sleep. So predominantly PLMS you will find in N2. The easy thing to remember is that REM is atonia. So how will the patient have a movement in your REM sleep when the body is under atonia? It's logical. So predominantly the PLMS will predominate in the N2 sleep. There is another pattern which is less common where PLMS is evenly distributed throughout the sleep cycles, peak movements occurring in the middle of the sleep. So the first one, the classic pattern, we must know that when you are interpreting something like if those who are equipped and used to report PSG in level 1 PSG labs, and you have the habit of, while reporting, you have the habit of looking at your cameras and looking at the patients. So there you can see that PLMS is predominantly occurring only in N2 stage, and it diminishes in N3 and REM sleep. PLMS obviously, as with RLS, will obviously lead to some kind of sleep fragmentation because sometimes it is associated with arousals, non-restorative sleep, what we call as excessive daytime sleepiness, poor concentration. In children, as we said, that pediatric PLMS and ADHD are very commonly correlated with each other. So up to 50% children with ADHD may have PLMS, and up to 90% children with PLMS have ADHD. So this is very, very, very important. If you have a child referral, you are doing a sleep study, and a child is somehow picked up by neurologists or suspected with ADHD or either way vice versa, then PLMS and ADHD have a very strong linkage in between vice versa and both ways. ADHD may worsen PLMS sleep-related fragmentation. PLMS may worsen symptoms of ADHD, and there can be increased frequency of nightmares and nocturnal aneurysms. Age, male gender, concomitant presence of RLS, and drugs like SSRIs, SNRIs, and tricyclic antidepressants can induce PLMS as well, plus minus association with smoking, diabetes mellitus, and AHI. So the treatment part, you see this slide I just actually missed in the RLS, usme I had put it in the before the management somehow. But predominantly when we talk about treatment of PLMS, please remember the treatment grossly remains the same. So I will just quickly take you through the PLMS what we have discussed. It's very common to have RLS patients with PLMS. 80% of RLS patients will have PLMS. Grossly same pathophysiology, same kind of management. PSG, PLMS diagnosis requires a sleep study, type 1 sleep study. RLS can be diagnosed in OPD setting. PLMS will require a PSG diagnosis. Criteria are they just like AHI criteria for OSA, just like that we have PLM index for severity of PLM. PLMS phenotypes are there. What difference does it clinically make? I don't know, but predominantly it's basically research purpose or prognostication wise. PLMS in children is more important. Cutoff is different. PLMS has a strong association with ADHD. One must know. Common pattern. It starts in N2, starts in N1, peaks in N2, and disappears in N3 and REM sleep. Association with ADHD of PLMS we have discussed, and some risk factors we have discussed. Treatment remains the same as RLS, so there is not much of treatment. In separate treatment in PLMS that is there. Thank you very much. This was about the presentation, and now I take you to Dr. Jeraman sir, please, if we can go ahead with the panel discussion and all.
Please proceed with the panel discussion. Please, sir, please proceed.
Okay. So I'll go ahead with the panel discussion. So we have three panelists here. Dr. Mahesh Babu, Dr. Sheenu Singla, and Dr. H.M. Sau. And I was a bit apprehensive when I came to know that there are two neurologists in the panel discussion because, they can point out your mistakes. I'm always aware of talking about sleep with neurologists, but that should be okay. Just a second, please. So I just make sure all the three panelists are there online, sir. Dr. Mahesh Babu, Dr. Sheenu Singla, and Dr. H.M. Sau.
Yes, sir.
Yes. Okay. Just a second. So, first I'll go with you, sir. Dr. Sahu, sir. Any comments on you on this? Then I will come on the controversial parts of the topic.
Yes, sir, you have presented very nicely. I would just like to point out a few things about RLS. When we think about the dopamines, actually in the brain, the dopamine, the chemical that is not decreased, but rather the dopamine receptors in the postsynaptic junctions, they are decreased. First thing. Second thing is that when you look at the iron profile, iron is getting absorbed from the intestine, but they are not going into the mitochondria of the neurons. That's where the problem lies. The cytosol is full of iron, but the mitochondria is not getting the iron. Probably there is some problem from for the iron to go from the cytosol to mitochondria. These are the two important things in the pathophysiology that I wanted to highlight. Third thing is when we look at the fMRIs, functional MRIs. Actually, the most sensitive reasons that are associated with this RLS are the basal ganglia, the thalamus, and the substantia nigra. That's all from me. Any other panelists want to add anything?
Dr. Shinu Singla, please, if you are here.
Yes, I just want to add further thing in the Dr. Harmon's thing. Actually, in the iron part, there is a decrease in the iron in the radicules and the substantia nigra of the midbrain. And as compared to the dopamine, as we've seen, then there is decrease in the dopamine receptor, DAT receptor, dopamine transporters. They are decreased, and there is D2 receptors also decreased in the corpus striatum. That is the putamen and the globus pallidus of the basal ganglia part. And
Yeah, I actually did not go into that detail in the pathogenesis before that, but it's okay. You can make your point, and it's very welcome. Actually, okay. And Dr. Mahesh Babu, please, if you are here.
Yes, sir. Sir, it was a nice presentation by you, sir. And as the panelist Harmohan Sahu sir and Shinu ma'am told, all the means like that iron thing should be the routine thing we have to do. That ferritin iron studies should be done routinely. This thing. So and mainly our diagnosis will be based upon the history. This thing mainly RLS thing mainly based upon the history, which we mostly miss out. This thing, as you have rightly pointed out in the initial slide itself. This thing, yes, sir.
So thank you all of you. But there are certain points which are still debatable, on which the data is less or which the consensus is less. I'll come on to with this some few questions on the controversy part of it. My first point to Dr. Shinu, as a neurologist, I would like to ask, what do you think as a neurologist, since there is so much of an overlap between the two entities, do you think that still RLS and PLMS should be considered as manifestation of the same disease or not? Do we treat them as, because the treatment is the same, the overlap is so much, around 80% RLS patients have PLMS. So what do you have to say if I say you that are RLS and PLMS manifestations of the same disease or considered to be as separate diseases? Dr. Shinu, please.
So although they are the same physiology, pathophysiology, and the same treatment is there, but mostly RLS 80, like have you said, as already you told that only 80% of the patients of the RLS have the PLMS, but only 30% of the patients of the PLMS have RLS. But RLS is usually in the awake stage, early in the night. It is usually in the evening. Patient is waking up, and in the whereas in the PLMS, it is mostly in the deep sleep during the middle of the night in the N2 and N3, N1 and N2 stage. We usually find the PLMS. Basically, PLMS is an polysomnographic finding. It is not the finding, but RLS is the OPD finding, and we can treat the RLS only on the basis of OPD clinical symptoms. So, if we, as per the severity, if we find that there are more PLMS and the polysomnographic finding, but the clinical symptoms are very less, so we don't have to treat the PLMS. We usually we have to find any sleeping, breathing disorder, any like ADHD. We have to treat that disorder first, and then PLMS usually automatically treated with this disorder.
Thank you, Dr. Shinu. Actually, you just ended by saying what was my next question, which was I was going to ask with that. So I'll go on this question to you with Dr. Sahu now. So see, Madam actually just ended by saying that sometimes periodic limb movements with a significant PLM index are encountered incidentally in patients undergoing PSG for OSA. Yes. So what do you say that where and when does one decide whether to treat PLMS separately or not? So that is very important. Or in simpler words, what is the clinical utility of PLM index?
Yes, sir.
Rahul.
Actually, many patients are there who are not usually aware of this PLMS. We only find in PSG, but there are certain group of people who usually come to us with a recurrent awakening from the sleep. They are having a such severe index of PLMS that it is disturbing their sleep. I had one patient. I remember he was having actually RLS as well as PLMS. PLMS index was almost 40, and he was not able to sleep at night. In the early phase of sleep also he was having awakening, so he was one of the difficult patients of mine. I started him with dopamine agonist, but the patient had such severe symptoms that he also did not respond simply to dopamine agonist. I had to add clonazepam along with it to give him some sleep to this patient. Actually, clonazepam in this patient actually does not reduce the severity of RLS and PLMS, but it helps you to initiate the sleep actually. So this patient actually responded after addition of clonazepam, and later on I was able to tapper off the clonazepam, and he was doing fine with this dopamine agonist. So this kind of patient we do encounter who are having severe PLMS index, as well as this quality of life is also hampered because he is not able to sleep properly. So he is having excessive daytime sleepiness. He was having poor quality of life, very anxious and depressive. Every day coming to my OPD, sir, I was not able to sleep. What will I do? So this kind of patient do come to your OPDs very often.
Thank you. Thank you. Now, while we are talking about RLS, we have repeatedly been saying that RLS is predominantly an OPD diagnosis and it does not require PSG. So now I'll come on to Dr. Mahesh Babu. Sir, have you encountered, or can you just say that if RLS is predominantly an OPD clinic diagnosis, so is there any indication or sometimes you would do a sleep study, a PSG in a patient of RLS?
Sir, actually, mostly routine PSG is not required for diagnosis of RLS, sir. But if it is indicated mostly in cases of where diagnosis is uncertain, like that sensory feelings. If you do mostly this RLS are sensory motor disorder. So if the diagnosis is uncertain, in such case it can be advised. Or if along with the RLS, if there is any PLMD, if we are suspecting, if we want to know the PLMD, in such cases also PSG can be advised. And also if other comorbidities like OSA or your parasomnia or your narcolepsy, if it is suspected along with that, then also PSG can be done. And if even though after treating the RLS symptoms based on history, after that also, if still the symptoms are there and still patient is not responding to the treatment, then in such case also, then we can consider for polysomnography. This thing, and basically if we require for documentation sake, then also maybe lastly we may require for doing this PSG.
Predominantly, you are saying that it's basically not purely RLS. If RLS is having some kind of association, some other disease other than that, so for that PSG can be done, not purely for classic RLS.
Yes.
That is fair enough. That is
Yes.
fair enough. And the one difficulty which I am always facing in, whenever there are children referred for sleep study, I am very much uncomfortable in handling children in sleep study. So my question is to both the neurologists: how frequently do you see children with RLS? Because children will, give you vague symptoms, and you cannot classically call upon the diagnostic criteria for RLS in a children. They will give you vague symptoms. So do you actually encounter children with RLS, and if yes, what challenges do you face in them?
So mainly the symptomology, as you told, that they usually tell us that something funny that is in the legs, some insect is crawling in their legs, or some spider is crawling on their legs. So usually, mostly pediatrician usually label this as the growing pain, which is totally different entity from the restless legs from the RLS. and some we have to usually this is rare. This is usually estimate under recognized problem in the children because of the symptomatology, because children can't express their issues to the doctor. So if any child present to us with ADHD, we have to rule out the RLS by doing the polysomnography in that patient.
I have a few patients, pediatric patient, actually 8 to 9 years, 2 to 3 of them. They had these symptoms. They only complained of leg pain at night. So I started them on very low dose of gabapentin and they have responded. I have given them 50 mg gabapentin at night. After 2 to 3 months, they have been apparently fine. They left the treatment for 5-6 months, and after that, one patient came back. I am having the same symptoms once more. See, so I have also started him on the same medication again, and he is doing fine. So sometimes this patient come to me.
Dr. Sahu, I'll continue with you with one more aspect, which is a bit controversial. That is about the ferritin cutoff levels. The indication of oral IV therapy in iron is also a matter of debate. In fact, one of the literature I was studying about, which I actually haven't kept in mind very frequently, about which machine are you using for measuring serum ferritin levels and different cutoff levels in different places. So is there anything you would like to talk about that, about the ferritin cutoffs which are to be used in treatment or not treatment?
Sir, what the guidelines tell that you can give it below 75 ferritin level, but I have seen some patients even above 75. Also, some patients have responded to oral iron therapy because these patients, you see, some patient will come to you with RLS symptom. You have started dopamine agonist, still they are not doing fine. You see the iron profile, it is perfectly fine, but these patients have responded to IV iron therapy. Two old senior, one gentleman and one lady was there. Their iron profile was completely normal, above 75 ferritin level. Still, I gave them IV iron therapy and they responded very well. So sometimes, rather than thinking of the cutoff, you see the clinical symptomatology of these patients.
Yes. Agreed. So basically individualize and customize the case and go on to see the symptoms, whether the patient falls into that chronic persistent RLS, severe RLS, then you can actually modify your cutoff levels also.
Yes.
So there is one last question from my side to all the three panelists actually is that since the guidelines have changed and now the dopaminergic drugs are not the first standard line of treatment, so I personally would admit that we have limited experience in giving these newer drugs to patients of RLS. So what is your take on, this gabapentin? Neurologists must be using it more frequently. I admit that. But I would like to know the pulmonologist perspective also, that how frequently are you able to use these newer conventionally neurology drugs to treat RLS? Basically, how much experience do you have and what is your take on that? Especially when this horizon is not available, at least in MP it is not available.
The response to the drug, like the gabapentin and the pregabalin, is not that robust as in that case of the pramipexole dopamine agonist. Response is slower, but the side effect profile is very high in the gabapentin and pregabalin. Their sedation is there, drowsiness is there, weight gain is there with the pregabalin, and ataxia sometimes will happen with the gabapentin. More of side effect profile with the gabapentin. So our first choice is the dopamine agonist. If the patient not tolerate the dopamine, then we have to shift to the gabapentin.
Thank you for being honest. that gives the pulmonologist some confidence that even you are using, you also want to use the dopaminergic drugs as the first line as of now. Thank you for being honest about that. Dr. Babu, Dr. Mahesh Babu, as pulmonologist, would you like to say anything about that? Dr. Sahu, you will just.
When in our hospital, we are using this dopaminergic agonist first, and then only this alpha 2 delta gabapentin and pregabalin we are using, sir.
Okay. Dr. Sahu, you were about to say something.
So the problem with the Indian population is that they do not tolerate high doses of gabapentin and pregabalin, and the patient, if you are going at a start of 300 mg gabapentin or some more than 75 mg pregabalin, many patients do not tolerate, but they do quite fine with dopaminergic agonist 0.125, 0.25, like that. So if the patient is ready to tolerate the pain and take the side effect, then you can think of, but with low doses, they usually do not respond. I have some patients who are having actually diabetes along with RLS, and some patients are neurogenic pain due to some PIVD or something, they are also having RLS. So these patients I have tried with gabapentin initially, and they did not respond. I came back to using dopaminergic agonist along with gabapentin. They have responded well.
Thank you. So that actually gives you a message that probably it is still not a crime to continue using dopaminergic drugs, if at all, at least in Indian population. I am actually glad to know that. So, Dr. Jayaraman, I think we are done with the. If anybody wants to add anything, I think we are done with the controversial questions or which you had,
There's certain
required
questions
this
in the
thing.
chat box, sir. Just
Yeah, I can. Yes,
go to
yes.
the
I'll
chat
just.
box.
I'll go to the chat box just quickly. I can see that most of the questions have actually been answered during the presentation. If I can see something, this is one question which I think we can answer. Can we recommend pramipexole in all age group patients? I think it's not very much established therapy in children. Any comments, Dr. Shinu, about this?
Not prescribed,
Dopaminergic drugs in pediatric population or all age group? Somebody has asked.
or not prescribed in the children actually, and not in.
Not to be prescribed in children. Yes. Meditation and pranayama and snoring. Please understand, I'll just respond by one line. OSA is a multifactorial disorder. All these things, yoga, pranayama, meditation, they are adjuvant therapies, but you do not replace the primary therapy, that CPAP, if you have diagnosed one OSA. And then investigations for RLS, basically it's a clinical diagnosis, but yes, iron profile we have discussed, that should be ordered in every patient. Okay. Elderly females, it's more common in younger females, but yes, elderly females can also be affected and they are usually affected sometimes, but more common in younger population. Any association between pediatric mouth breathing disorder and RLS?
That is the OS.
Can I say about this? This is a pediatric mouth breathing disorder. In general, you're talking about OSA. So RLS and OSA can coexist, but I don't think you will label something as pediatric mouth breathing disorder. Go for OSA. The most common cause of OSA in children is tonsillar enlargement and all that. So these are two separate pathologies which can coexist together. That is, I would like to say. So I think that's most of the questions I think are covered here in the chat box also. Dr. Jayaraman?
So there is
anything
one
else
question
on your
from
side, please?
Odisha, Dr. Daneshwari. How to suspect these disorders by other family members? The patient himself, they will tell. Family members, how to recognize whether is it sleep-related movement disorder, RLS and all this. That is Dr. Daneshwari is asking, sir.
How to suspect these disorders by other family members? Dr. Sahu, would you like to answer this thing? How to family members?
I have actually two families, father, elder son, and the younger son. Three of them are affected. Father is 56, elder son is somewhere around 30, 35, younger son is 16. But they come to you with the similar kind of presentation. When they come with the similar presentation, they have already made a similar diagnosis in the family only. The father brings the elder son, he is having the same problem. Bringing the younger son, he is having the same problem. So when they come with the similar problems, you can only diagnose. Otherwise, no choice.
Dr. Jayakishan sir has asked about any algorithmic approach to diagnose RLS. Sir, diagnosis of RLS is predominantly clinical. There is no algorithmic approach, but if you talk about the treatment part of RLS, then there are articles with certain flow charts. You will find out that first make a diagnosis of RLS, get the iron studies done. Iron less than 75 hai to ye karna hai, ferritin more than 75 hai to you go with the iron therapy. Treatment part mein you can have some kind of a flow chart which you will find in the literature, but diagnosis is usually clinical. There is no algorithmic approach as such to make a diagnosis, I would say.
So there is one question from Dr. Shivani Swami ma'am regarding do you usually give iron therapy to all patients? There are some views of giving iron irrespective of iron levels.
We, madam, usually will not give iron therapy. At least my experience is that iron therapy is not to be given in all patients. No. Get an iron studies done. and only then you decide whether to give iron or not, and depending on the severity of the symptoms and the cutoff values both, then decide oral or IV iron. So my answer will be not giving iron therapy in all the patients. No. Although anemia is very common in India still, you need to get the iron study profile first. Any other question, Dr. Jayaraman, if you can find out?
Dr. Deepali from Ahmedabad, can PLM affect upper limbs?
Yes.
Hinu ma'am?
Sir, RLS PLM can affect any body part, but the main thing is the symptomatology with the diagnostic criteria it should meet, like the urge to move. Sir, you are talking about RLS or PLM? PLM.
Actually, I am confused by this only because RLS you have known variants. For PLM, in fact, I am also, PLM by definition is leg movement disorder. For RLS, definitely you have variants where you will find patients with different kind of repetitive habits like chewing gums or rubbing your back or something like that. RLS can definitely spread to parts other than limbs, but PLM, so by definition, it's like limb. Dr. Sahu, anything want to say?
Yes, sir. Actually, in some patients of Parkinson's, like RBDs, type of features can appear in upper limb, but PLM, I have no idea.
It's by definition it is leg movement, but RLS, yes, you have variants which can affect the other parts of the body. There is no doubt about that.
Then question from Dr. Sugita Raj, investigations for restless leg syndrome.
Iron studies.
Dr. Babu, Mahesh Babu.
Sir, investigations, first thing is history set. This thing, you have to ask for the history and then see for your mainly iron studies. This thing. That is the main investigation we have to do. This thing. RLS diagnosis is mainly by the history. And if we want to document, then we have to go with your polysomnography. This thing. And in every patient, we need not do OSA. This
and you have to, because of the association of RLS with this kind of, diabetes and anemia, uremia and all that stuff. So these kind of routine investigations like sugars and ruling out a known chronic kidney disease, these things are important. Otherwise, specific to RLS, if you talk about, then iron studies.
Yes.
So please check any other questions in the chat box. I don't think.
I think we are almost done with all the questions which are in the chat box. Dr. Ghulam Hassan asked initially, can PLM be scored during OHA? Well, I think we have covered this already. PLMS can be incidentally encountered in OSA patients during sleep study, but whether to separately treat that PLMS or not is a matter of question to be discussed. I would personally see that if you would treat the OSA first and then only, talk about PLM. Most of the PLMs will actually get settled with OSA only, unless it is very severe, more than 60-70. Otherwise, I would rather treat only OSA and then wait and watch. That's it, Dr. Jagaraman. I think we are done with almost every question here.
Thank you very much, sir, for the wonderful panel discussion. I thank you, speaker and moderator, for the lucid presentation on restless leg syndrome and periodic leg movement disease. Thank you, Alkesh Purana sir, for the wonderful moderation. I thank you, Sinu ma'am, for the beautiful address about all the questions, Dr. Mahesh Babu and Dr. Harmohan Sahu for the beautiful, wonderful presentation and wonderful answers for all the questions. So I request our technical team to project the slide of our forthcoming conference of 8th International Conference on Sleep Disorders. I welcome all of you. Please join our 8th International Conference on Sleep Disorders at Ahmedabad on So I request everyone kindly join in this conference. Technical team, Bijal, can you post this presentation slide? Bijal ma'am? This is the 8th International Conference along with the Australasian Sleep Association. So we'll be doing at Ahmedabad on 21st to 23rd August, Friday, Saturday, Sunday. We have a pre-conference workshop on 21st. There are 6 kinds of workshops we are planning: polysomnography, NIV, periodic sleep for the technologist and the ENT perspective and a lot of things. So this is our conference slide. Welcome all of you to join this prestigious International Conference on Sleep Disorders, CSM 2026, Ahmedabad. So welcome to join everyone for this conference. So we have 25 days more. Kindly register and welcome to join. We all see at our Ahmedabad for this 8th International Conference. So welcome all of you. So thank you very much for the wonderful participation in this prestigious webinar organized by the CSM, Southeast Asian Academy of Sleep Medicine. I thank you, speaker and moderator, Alkis sir, and all the panelists, Sinu ma'am, Magesh Babu sir, and Haramohan Sahu. So thank you all delegates for the wonderful participation. I thank your technical team. I thank our sponsor Cipla for the wonderful arrangements for this knowledge dissemination through this CSM. So thank you all. Good night. Long live CSM. Thank you. Good night.
Thank you.
Thank you, sir.